So good afternoon. Thank you for the introduction. My name is Boas-Ribeiro, and in this presentation I'm going to show you the latest work that I'm working on, which is comparing the MRI-only treatment planning with the current treatment planning in the clinic. So as you all know, to have a successful hyperthermia treatment, there are 3 factors that are very important: patient condition, patient comfort, and treatment quality. And we know that treatment quality can be measured by thermal dose, and it was shown by Martina Franchina that it is highly correlated with clinical outcome. And yesterday, also by the presentation of Petra Cox, she also showed that doing a very good treatment planning, also we can assume that we can predict the SAR distribution, and it is also highly correlated with the temperature distribution. So with all these assumptions, we can assume that predicting treatment, that doing a good treatment planning, we can predict thermal dose and also treatment quality. Stating this, in this slide I want to show you exactly what is the difference between the treatment planning and the current treatment. And in the left side, we see that the treatment planning is based on the CT. So we take the CT, the patient is laid down in the hammock, and then during the treatment, since this is MRI-guided deep hyperthermia, the patient is inside the device and with the water bolus filled. So the main idea is that immediately you can see that the position can be different due to the water bolus pressure. So what I want to compare in this work is, if we take into account this water bolus pressure, will the planning be different or not? So for start, I will talk about the state of the art of how we are doing treatment planning at Erasmus MC. And we usually start with a CT. We do the segmentation, and from this segmentation we acquire a 3D model of the patient that, combined with the 3D model of the applicator, we optimize it, and we acquire the best antenna settings to have the best coverage in the tumor. And with this, we have the best antenna settings, for sure also the target distribution. And since the treatment is inside the MR, before we start the treatment, we already take 2 different scans, the localizer scan and the initial scan, and this is to check the positioning and if it agrees with the treatment planning. Once this is checked and it agrees, we start the treatment, and the monitoring is done for sure using MR thermometry and also using invasive temperature measurements, which is the thermal probes, and we also adapt the treatment according to the patient comforts. So how can we improve? And for sure it will be to include the device, the water bolus pressure. So we look to the 2 different scans that we already acquired, which is the localizer scan and the initial. And the first observation is that the localizer is too low resolution. So we start looking to the initial. And this initial scan consists in 25 slices, where the middle slice is centered in the middle of the tumor. And then we did the normal treatment planning, which we did the segmentation, and then we acquired the 3D model of the patient. And as you can see in the image, the volume is quite small, and it doesn't include the full volume of the patient inside the device. So this didn't work out, so it was a need to have an MR image that actually contain the total volume inside the hyperthermia device, but also that gives us enough resolution in order to delineate other tissues than just fat, bone, and muscle. So this is how we came up with the new MR protocol. So this is a commercial version of the commercial propeller MRI version that is available in the GE scanner at Erasmus MC. And what I wanted to point out here is that you actually can see the water bolus and the contour. And also we include a little bit more volume outside to also, to do the planning. So the main goal, as I said, it is always to mimic how we are doing in the clinic and see if there is space for an improvement or not. So this is we are doing you are applying this MR protocol in volunteers, and we always start with positioning the volunteer in the hammock, and then we do the scanning. All the procedures is done inside the MR scanner. Then we ask the volunteer to get up and then in order to be able to try to reposition the volunteer in the same position as in the CT position. So the first part we consider the CT-based planning, which is how we are doing in the clinic, and then the MR-based planning, since it already includes the device and also the water bolus is filled. And then the workflow is the same. So we do the treatment planning first to using the CT position, we optimize the antenna settings, and then in the MR-based planning, we also do the treatment planning using this position, and then we apply the same antenna settings in order to compare. So the first observations that we saw is that there is for sure a deformation in the abdomen region of about 5 centimeters. And also if you look up to the shape of the body is also already quite different. And then using also the pubic bone as a reference point, we also saw that there is a displacement in terms of position of about 5 centimeters in the X direction, 3.7 in the Y, and 3.2 in the Z. So for sure there is a deformation. So we wanted to look also this if actually has an effect also on the SAR distribution. So we looked to the SAR, and we also look to the THQ, which is actually the parameter that we are using to optimize antenna settings in the clinic during treatment planning. So in the first part, we look up to the CT optimized settings and compare the two positionings. And we see that, as it was expected, the THQ in the CT is much better. And in the MR positioning, we see that there is a decrease of about 12%. Then we re-optimize these antenna settings according to the position in the MR. And we saw that there is even it goes back to the same THQ of the CT positioning, and it's even slightly better. So with this, we can already draw some conclusions, preliminary conclusion, let's say. So the first one is that the water bolus indeed has a considerable effect on the anatomy, and we should include it in the planning. And also when we do the planning using the MR, we also see a relevant improvement. And this improvement I based on the paper, on the study made by Kenters, where it did establish a relationship between the change in THQ and the change in T50. And he said that when there is an increase of 5% in THQ, there is a significant difference. So when we compare, using the CT optimized settings, we see that there is a 12%, which is translated to 0.58 Rs. And then when we re-optimize it, we see that there is a 15% difference, and which is almost 1 degree, so which is quite high. And with all of this, for sure we need to do still more assessment in a larger group, because this was just done in one volunteer. We are working on that. And yeah, so this is the end. Thank you very much for your attention.
Thank you very much for this interesting presentation. And are any specific question about this MRI treatment planning? So if not, thank you very much. Oh, you have.
I was wondering how long this new scan protocol would take and whether that would have implications on the clinical routine if you were to implement it.
Yeah, so the time is 8 minutes. So that's the reason why we need to expand the study also to a more larger group of volunteers before we want to apply in the clinic. So it will be more 6 minutes than usual, which is quite a lot. Yeah.
So thank you very much.
Thank you.